Okay, so now we're going to go over some of the specific disorders dealing with gynecology. So the first one we'll talk about is pelvic inflammatory disease, commonly called PID. So PID is just an infection of the reproductive organs. There's varying degrees of it and complications and involvement depending on exactly how severe it has progressed. So PID can be a complication of an STD, but it can also occur from other infections as well. So it's not always specifically related back to an STD, right? But what happens is you've got some kind of organism, usually bacteria, that's entered through the vagina and migrates to the uterine cavity. It could go potentially to the fallopian tubes. It may just be in the cervix. It could be in the uterus. So it really just depends on the overall severity. In some very severe cases, it actually can turn into peritonitis, and you may develop pelvic abscesses as well. Now, with this, because PID can affect the fallopian tubes and the ovaries, it can have long-term complications that can include infertility and increased risk for ectopic pregnancy as well. Alright, now your signs and symptoms, typically the pain is going to be reported as starting during or after maybe normal menstrual cycle. It's usually going to be kind of a diffuse pain that's spread out kind of equally over both quadrants of the lower abdomen. Maybe an achy pain. They a lot of times will also report that it's made worse by intercourse or by walking. In fact, you may see something called the PID shuffle. It's like this shuffling gait. And it's where they don't really want to put a lot of pressure down on the heel as they walk, because it kind of pushes shock waves up through the legs and into the lower abdomen, which can cause more pain. Other signs and symptoms, you may see some vaginal discharge, may have fever and chills, may have pain or burning with urination. Now, some of the risk factors, alright, untreated sexually transmitted diseases, frequent unprotected sex with multiple partners, using a douche as a cleansing agent. The vagina is kind of like a self-cleaning oven. It just does its own thing. You should not squirt up extra stuff in there to help clean it. Right? Having a history of PID, having it before makes you more likely to have it again. Having an abortion, whether it be a miscarriage or a medically induced abortion. Having an IUD placed. Now, typically your increased risk for PID is usually limited to about the first 3 weeks after placement of an IUD, but it could happen, at any point after that. Alright. So, management. It's going to require antibiotics. It's going to require a doctor. Things that we can't do. Alright, so our pre-hospital care here is going to be supportive care. We're trying to make them comfortable, transport them gently, just take them to be evaluated. Alright, Bartholin abscess. So this is where you get an abscess or a cyst that develops in that Bartholin gland and causes infection. Alright. Normally, this gland, this little duct there, just secretes mucus that acts as a lubricant during intercourse. Okay, but if this duct becomes blocked, it can cause that gland to swell, and then the abscess can develop to that cyst or gland itself becomes infected. Alright, usually in and of itself is fairly small. If it becomes large or infected, you could have vulvar pain. You could have a painful lump somewhere on their labia, usually in the lower portion. They could report painful intercourse. Now, there are 2 glands, one on each side of the vagina, so you could have unilateral or could have bilateral, just depending on if one or both of the glands are blocked. Okay? If it is infected or there is an abscess, they have to do a surgical incision and drain the infected gland. We don't do that. So, our treatment, our care pre-hospital is going to be supportive care and transport to an appropriate facility that can deal with it. Alright, vaginitis. This is just kind of a collective term for any inflammation of the vagina caused by an infection. Now, it's important because it can spread upward to the cervix, the uterus, fallopian tubes, ovaries, and can eventually potentially turn into PID. So, general common symptoms of vaginitis: itching, irritation, a discharge of sorts, an odor, usually a malodorous odor, painful intercourse, lower abdominal pain, just very kind of vague gynecological symptoms, right? Now, there are several different types of vaginitis, one of which is a vaginal yeast infection. And this is caused typically by Candida fungus. Normally, the kind of acidic environment of that vagina keeps the yeast from growing, but if they've taken antibiotics or something of that nature, oral contraceptives sometimes can alter the balance, the pH balance of the vagina. Menstruation, pregnancy, some types of douches or sprays or tampons, things like that, can basically get the balance in the vagina out of whack and can cause or allow rather the yeast to bloom and kind of grow out of control there. Alright, so signs and symptoms of a yeast infection: itching, burning, may have soreness in the vagina around the vulva, may have some swelling around the vulva, possibly a thick white vaginal discharge, probably going to smell kind of funky, pain during intercourse, and they may have burning upon urination. Another type of excuse me. Another type of vaginitis is vulvovaginitis, and this is inflammation of the external vulva. Signs and symptoms of this: redness, pain, swelling, discharge, burning, itching. A lot of the same stuff as just general vaginitis. So with this, they need to be evaluated by a physician. There's not a lot we can do. Okay, if it's not treated, it can lead to infertility, preterm birth, endometritis, PID, things like that. Treatment's going to be antibiotics. Our pre-hospital care is going to be supportive care, and nothing we can do for it. Now the next one is cystitis. So this is dealing with a bladder infection. And you might be like, well, why is the bladder in GYN? Because men can have bladder infections too. That is true. But women typically are more prone to having cystitis because the urethra is much shorter than it is in a man. So they have more common to have this issue. So they put it in here. So UTIs, all right? We all know UTI, urinary tract infection, right? This is going to cause by bacteria that's going to usually make its way up from the anal area into the genitalia. This is why we wipe front to back, not back to front. But the bacteria gets into the urethra opening and makes its way up into the bladder. Most often presentations going to be suprapubic pain, cloudy urine, perhaps a funky smelling urine, increased urinary frequency. They may, in severe cases, have some hematuria, and they may have a dysuria, difficulty or painful urination as well. Now with cystitis, if it's not treated, it can lead to pyelonephritis, which is a kidney infection. That's much more severe, and they can become very, very ill. Fever, chills, vomiting, nausea, the whole 9 yards. So with this, as far as pre-hospital pain or pre-hospital treatment goes, it's going to be predominantly pain relief and supportive care. All right, we can't fix it. They need, once again, antibiotics. Now the next thing we're going to talk about is, or there's a couple of ovarian disorders. So the first one's going to be an ovarian cyst, and this is just a fluid-filled sac on or within the ovaries. Now initially it may be asymptomatic. Most of them are asymptomatic. They can last, a month, 2 months, a couple months before they just kind of go away. All right. Now, when they increase in size, or in certain cases, they may cause a little bit of pelvic discomfort. They may cause urinary retention or increased urinary frequency, or even some irregularities with the menstrual cycle if they get severe enough. All right. It can actually spontaneously rupture. Right. Could rupture post intercourse. It could be from vigorous exercise, things like that. So if the rupture occurs, they may or may not have any symptoms. If they don't have any symptoms, well, obviously they're not going to call you for it, right? But if they do have symptoms, they typically are going to report a sudden onset of kind of a moderate to severe lower abdominal pain. It may radiate to the back. All right, if it's severe enough and they have internal bleeding, they may have a little lightheadedness or other signs of shock, hypotension, tachycardia, although that is fairly rare. Okay, they also may have a small amount of vaginal bleeding. So our management, supportive care. We can't fix this in the pre-hospital setting, so supportive care, transport to an appropriate facility. The next one is an ovarian torsion. It looks like somebody was studying for their Boy Scout not badge and went to town, right? So with this, An ovarian torsion is just a twisting of the ovary, and the problem in that is that it's going to cut off the blood supply. It can interrupt the blood supply there. Right? You need to think about this if they have severe lower abdominal pain or if the symptoms are getting worse. It is more common in patients who have a history of cysts, so if they've had cysts before, then it makes more likely to have an ovarian torsion. Something about having that cyst makes it more prone to kind of twisting on its axis there. All right? An ovarian torsion is a medical emergency. It is a surgical emergency. It can lead to permanent damage or loss of that ovary, which down the road could lead to infertility. With this pain, it's usually going to be an acute onset, all right, moderate to severe unilateral pain in that lower abdomen that's going to increase over over a period of hours. The pain may be intermittent, so it may kind of come and go. It may radiate to the back, the pelvis, the thighs. They may have some nausea and vomiting. But you know, the nausea and vomiting is kind of a non-specific problem, so it really doesn't help much. And you know, and if you don't have those findings, that doesn't rule it out completely. So our management, our pre-hospital management for any kind of ruptured ovarian cyst or suspected ovarian torsion is going to be recognition, transport to an appropriate facility, and treatment of any symptoms as they arise. All right, endometriosis. Now there is endometriitis as well. Endometriitis is inflammation of that endometrium, the uterine lining, and this is usually associated with a bacterial infection. Women are more likely to have this after having a miscarriage or after having delivered. In most cases, in that situation, the signs and symptoms of endometriitis are going to occur within about 3 days or so after childbirth. Right? Fever, chills, vomiting, tachycardia, lower abdominal pain, cramping, foul smelling discharge. For this, comfort position, supportive care, IV fluids as necessary, and transport to an appropriate facility. Now, endometriosis is going to be where you have endometrial tissue that has grown outside of the uterus, and it's found usually in the pelvic structures around the uterus, so the ovaries, the fallopian tubes, maybe the bowels, the rectum. It just depends on the severity of it. With this, some women may not even realize they have it until they have difficulty trying to get pregnant. Your signs and symptoms, and these are the signs and symptoms for the endometriitis. We got a little bit ahead of ourselves here. As far as the endometriosis, your signs and symptoms may be heavy or prolonged menstrual flow, extremely painful menstrual cramping, painful intercourse. They may have a sensation of rectal pressure or urgency, may have fatigue, may have a menstrual spotting in between the cycle or bleeding in between periods. The pain may be described heavy, dull, aching, pressure, lots of different types of pain or presentations here. So with this, we are going to look at reassurance, position of comfort, IV as necessary, treatment based on signs and symptoms, and transport to an appropriate facility. All right, uterine prolapse. So this is where a portion or all of the uterus has come down through the vagina and maybe outside of the body, just depending. So we've got a couple of classifications depending on how severe the prolapse is. So the first degree prolapse is where the cervix drops but remains within the vagina. All right, the second degree is where the cervix lies at the opening to the vagina and the body of the uterus is in the vagina. And then the third degree is where the uterus and the cervix are actually protruding through the vaginal opening. Now, with this, you know, there's a lot of things that kind of contribute to this. Being obese, having a weakened pelvic support, weakened pelvic floor due to decreased estrogen and age, being pregnant, having had delivered a baby, prolonged labor, multiple births, large babies, repeated pregnancies. All of these things kind of contribute towards the possibility of a uterine prolapse. Now, the early stages of these of uterine prolapse may be completely asymptomatic. They may not know at all. But the more advanced stages, they may have like this pelvic heaviness or fullness, fatigue, lower back pain, things like that. And typically these symptoms will become worse after long periods of standing, and they feel better when they lay down. All right. So with this, if there is vaginal tissue exposed, if you can see it, if it's visibly prolapsed outside the vagina, cover it with a sterile moist dressing or gauze and transport to most appropriate facility. Now, you might be like, Jessica, wait a second. I thought with uterine prolapse we get that one attempt to push it back, right? Well, that's in OB. So, and it's specific because in a post-delivery uterus, the possibility of hemorrhage is much more significant in that situation. So it's considered to be an emergent situation, okay? An emergent problem. In this case, in a non-pregnant, non-post-delivery prolapse, it's typically more of a chronic long-term development thing. It's not considered typically to be an emergent situation. So that's why the treatment is a little bit different there. Now, for your dysfunctional uterine bleeding, that's any uterine bleeding that is abnormal in amount or frequency more than every 21 days. Okay, usually diagnosis of this is going to happen after they rule out all other kinds of problems. All right. You know, with this, and I mean, it's typically not going to be an emergent situation. It's going to be something that we recognize. Signs and symptoms: abnormal or large amounts of bleeding. Management: they need hormonal therapy or surgery. Guess what we can't do? Hormonal therapy or surgery. So pre-hospital care is going to be supportive care. Let them be in a position of comfort. If they have significant vaginal bleeding, use any dressings or towels or anything to absorb it as needed. The risk factors with this dysfunctional uterine: extreme weight loss or gain, being over the age of 40, high stress levels, having polycystic ovaries, long-term medication use like oral contraceptives, having uterine fibroids, excessive exercise. So there's lots of different things that can cause this. Right? Ectopic pregnancy. This is the one that we should all be super familiar with, right? So this is where you have an oocyte that has implanted somewhere other than the uterus. It has not gone where it's supposed to. Usually this occurs in the fallopian tubes. It can happen in the abdomen, in the cervix, on the ovary, but vast majority of the time it's actually going to be in the fallopian tube, which is often called a tubal pregnancy as well. Right? This can be a life-threatening cause of vaginal bleeding early in pregnancy. And to be fair, they may not realize that they are pregnant at this point because they may have had a menstrual cycle because the uterus didn't have an implantation, so it shed. All right, even though they are in fact pregnant. So your risk factors for your tubal or your ectopic pregnancies: having previous surgical adhesions or ectopic pregnancies, having or had PID, having a tubal ligation where they go actually basically like snip your tubes, having an IUD. All of these things increase the likelihood or the possibilities of having an ectopic pregnancy. If this occurs, if this implantation occurs in the tube, then it's going to start to stretch. And as it starts to stretch, you're going to start seeing some of the signs and symptoms. All right, your big three are going to be abdominal pain, usually unilateral, delayed menstrual cycle, and may have abdominal bleeding or spotting 6 to 8 weeks after the last normal menstrual cycle. Now, some women may misinterpret this, and this may be thought of as to having been that menstrual cycle as well. Now, as the tube stretches, it doesn't have that capacity that the uterus does to keep growing, so eventually this embryo is going to run out of room. And when that happens, the tube's going to rupture, which is going to cause pain, right, and can potentially cause life-threatening bleeding. So the pain typically is going to start as a dull lower quadrant pain on one side unilaterally, and it may be, change as it grows and stretches. It may change into like kind of a colicky pain, like a cramping intermittent pain, and then usually will turn into a sharp stabbing pain when it ruptures. All right, so sudden excruciating pain felt throughout the lower abdomen. They may even have referred shoulder pain if they're bleeding significantly and the abdomen starts filling up with blood. All right. So management, what do? This is bleeding we can't stop, right? So that makes it a surgical emergency. So we're going to make sure we've got an airway, make sure we've got oxygen as needed. Left bladder recumbent, we're going to do IV fluids as needed, large bore IV, anticipate the fact they might vomit, treat that if they do, keep them warm. Notice we're treating for shock here. Monitor the EKG as needed, and transport to the appropriate facility that can provide surgical care. Now, sexual assault. So any type of sexual contact or behavior that occurs without the consent of the recipient is considered sexual assault. Rape is a specific type of sexual assault that could be non-consensual oral, anal, or vaginal penetration by body parts or objects by using force or threats of bodily harm or taking advantage of a victim who is incapable of giving consent. All right, now something to, and that's the National Institute of Justice definition. Something to remember is that with rape, rape is a legal term. Okay, it's not a medical term, it's a legal term. We are looking at the results essentially of this sexual assault. Now, with this, being professional, being respectful, being very sensitive is really, really, really important here. There's a lot of complex issues that go along with sexual assault, psychological, legal issues, medical issues, and how you manage or mismanage the situation could actually have a lasting effect on that patient and potentially you. All right. Something to think about is that men and women can be victims of sexual assault. It is a crime, so you should expect for police involvement to be there. All right. If they have not been contacted so far, it is your responsibility to contact them. If you have a female victim, one of the first things you should start with your assessment is asking if they would be more comfortable with a female or a male paramedic, and try to make every effort to fulfill this request if possible. Right? Different people will have different preferences depending on perhaps what happened. Keep in mind, it is the job of the law enforcement officers to solve the crime, figure out who did it, and make sure justice is served. It is not our job. Our job as a paramedic is to manage the medical aspect of the case and to act as a patient advocate, okay? So there's several key issues that we really need to think about when we are taking care of them. So the first issue is going to be the actual medical treatment, okay? We want to limit any physical exams to just a very brief survey for any life-threatening injuries, okay? Expose and examine the vaginal or the anal areas only if there's evidence of bleeding that needs to be treated. And we want to make sure we do everything to protect their privacy and give some sense of control back to the patient. We want to make sure that we're interviewing or examining the patient with the minimum people necessary, okay? We don't want a bunch of people around making them think through this and work through this again. Is the patient physically injured? Do we have any life threats? If not, is there, we're going to limit any physical exam there. Do they complain of any pain? All right, these are things that we're looking for. The second issue is going to be emotional care. We're not trying to cross-examine them. We're not trying to elicit any more information for the benefit of the police. That's not our job. That's the police's job, okay? That will be handled later on in the emergency department. We're not there to judge the patient. We're there to protect the patient, okay? When you are performing your assessment, make sure that you are being, you're aware and looking for any clues that suggest maybe the potential use of a date rape drug or a club drug, as they call them. So they may or may not know, but if they've had, been drugged, but if they can't remember something, that should kind of flag you for, hey, there's something going on here. Roofies, GHB, ecstasy, alcohol, Xanax, ketamine, all of these things can be utilized kind of to facilitate sexual assault. They can be put in their drink, they may go undetected, and it can make the patient weak, confused, more compliant, or maybe even unresponsive. Now with this, if the drugs are still in the patient's system, you may see hypotension, you may see bradycardia, difficulty breathing, seizures, coma, even potentially death there. So, management of a sexual assault. First and foremost, remember you're at a crime scene, okay? Your patient's body is a crime scene. We have a responsibility to preserve evidence if at all possible, okay? Our main job is to treat the medical aspects of the incident, but we still have a responsibility to try to preserve evidence. So don't cut through any clothing or throw away anything from the scene. If you have bloodstained articles, put them in separate paper bags if at all possible. Get evidence bags from police if necessary. Okay, paper bags allow wet items to dry naturally, whereas plastic allows like mold to grow and can start to kind of destroy any biological evidence there. All right, It may be necessary to try to talk that patient into not cleaning up. They may feel the need to go clean up and wash it away, any humiliation or embarrassment or anything that they may feel as a result of this assault. This destroys evidence. So we really want to try to discourage them from urinating, using hand sanitizer, changing clothes, bowel movements, taking a shower, rinsing out their mouth, anything like that, okay? And we can't stop them, but we want to discourage that. Some patients may actually refuse transport, and that is their right. If they're mentally competent, that's their right. So in that case, follow whatever your system's refusal of treatment or transport is, or their policy and procedures, okay? Make sure that you understand, if you can, why they're refusing. We really don't want to just be like, okay, sign here and leave. Make sure that we're following through, okay? Offer to contact a local rape crisis center for the patient. Most communities have a center with advocates on call. Right? Getting a professional advocate to scene may help them start to deal with the trauma, may help to, explain why they need to go to the hospital, why they need certain things have to happen. When you are writing your report, all right, it is a legal document. You do want to record, any kind of emotional states, condition of clothing, any obvious injuries. If you have something that the patient has stated, make sure that you use quotation marks to indicate that you're documenting their report of events. We're not looking to put our opinion in there as to whether they were raped or not, okay? We don't want to offer any conclusions that would validate or invalidate their account of what happened. We want to present the facts, record our observations, and just the facts, okay? Remember, rape is a legal diagnosis, not a medical diagnosis, okay? So we are treating any injuries or anything of that nature that can occur. And the last subsection of your sexual assault is going to be partner violence, and this is defined as your physical, sexual, or psychological harm by a current or former partner or spouse. So domestic violence, basically. Could be heterosexual, same-sex couples, doesn't really matter, okay? Our job here is safety, our patients and ourselves, okay? We may be privy to information that they don't get at the hospital, so make sure that you try to get all the information just like you would anytime you suspect abuse or anything like that. Our safety is priority in trying to get them to an appropriate facility.